Good afternoon. Welcome to this afternoon session, and thanks for staying late for this late session today. I'll be talking about coronary stent and evolution of coronary stent technology, and what are the implications for that for us in this year, because our guidelines just recently got updated. I don't have any disclosures that are relevant to this topic. And as far as the learning objectives, we will be talking about the pathophysiology, pharmacology, and indications for coronary stents. I will outline the management strategies for patients with coronary stents that are presenting to the operating room for non-cardiac procedures. We need to recognize the bleeding and thrombotic risks, which are very real in this patient population, and also identify the perioperative management strategies for patients that are presenting for elective versus emergent urgent surgeries in this population. So the outline of this talk will include the historical perspective. I will talk about the ongoing evolution of stent technology, which is certainly very relevant because we need to stay up to date to understand how to manage each patient. I will talk about the guidelines, which recently got updated, and then we will put it all together with a pragmatic case-based approach. So why is this an important topic? Of all the deaths that are attributed to cardiovascular diseases, you can see here that almost half of them are because of coronary heart disease. To put that in perspective, every 40 seconds, a coronary event occurs in this country. And in order to be able to deal with that, there are about 1 million percutaneous coronary interventions that are performed every year, including angioplasties as well as stents. And also the highest risk period for these patients is within the first year of stent placement. And a large number of percentage of patients, about almost 20%, will present to us to the operating room in this high-risk period, and it falls upon us to get them safely through this time. So, for example, this is a real case that might present to us. A 56-year-old lady with a recent diagnosis of ovarian cancer, with a history of typical problems like hypertension, diabetes, hyperlipidemia. She also has coronary artery disease, and for which she had a drug-eluting stent placed 6 years ago. However, she had an angiogram 7 months ago for chest discomfort, for which she had 2 additional stents placed in her right coronary artery. That was 7 months ago. She now has a normal ejection fraction. She has been placed on dual antiplatelet therapy by her cardiologist, including clopidogrel and aspirin, and they have recommended for her to stay on it for a year. However, now she's presenting with cancer, and she needs a total abdominal hysterectomy with a bilateral salpingo-oophorectomy and a tumor debulking. So I just want you to think about this for a bit, and we will come back to this case after I finish telling you about the evolution of coronary stents. And then try to think about how you would manage this patient in your setting. So let's talk a little bit about the historical perspective to understand how we got to where we are now. So the father of angioplasty is Dr. Andreas Grodzig. He performed the first successful angioplasty in 1977 in a 3-millimeter lesion in the left anterior descending artery that had 80% stenosis. He was a German-born physician, and he migrated to Switzerland, and then he was at Emory. However, it was very unfortunate. He died prematurely in a plane crash that he was himself the pilot of. He would have been very, very amazed and proud of how the development in his invention has progressed over the years. For historical interest, this is the first patient that he performed the angioplasty on. And as you can see, it's a very tight lesion in the left anterior descending right there. And this was when the patient was 38 years old. At age 61, 23 years later, the same patient has still got the widely patent vessel after the angioplasty, which is pretty amazing. However, not all patients that have angioplasties are that lucky or have that good of a result, because due to the inherent elastic recoil of these vessels, the vessels tend to collapse even after they are dilated after a period of time. And there is a very high reintervention rate, up to 30 to 40% that is needed for these patients. And in order to overcome that problem of vascular recoil and stent and collapse, bare metal stents were FDA approved in 1993. Essentially, they are just metal scaffolds that are placed in the vessels after dilation to provide a support structure to prevent them from collapsing. However, and of course it was successful, the reintervention rate decreased quite a bit. However, because this is a metal structure, it's a foreign body, it results in neointimal hyperplasia, much like scar tissue formation. And over a period of time, the patients that have bare metal stents, they end up with in-stent restenosis, which is gradual, happens over a period of, let's say, 6 months or so. And the symptoms gradually start to return, chest pain, and then they usually have to visit the cardiologist for a reintervention. So in order to tackle that problem, in 2003, drug-eluting stents were FDA approved. Essentially, it's just a platform, which is the stent itself, that is coated with a carrier. You can see with a polymer that is the carrier, and in which the drug is embedded. And this drug has anti-proliferative, immunosuppressive, and cytostatic or cytotoxic properties, and therefore it inhibits scar tissue formation. With the result of drug-eluting stent approval, there was a dramatic decrease in in-stent restenosis that we talked about, and there was an increased procedural success rate. However, did we solve the problem? So as is the nature of the game, the solution to one problem usually leads to another, and we already saw that the vascular collapse was prevented with bare metal stents, which led to scar tissue, in-stent restenosis, which led to drug-eluting stents, and that prevented scar tissue formation. However, it turns out that the drugs that inhibit the development of scar tissue also inhibit the regeneration of the vascular endothelium. And the vascular endothelium gets disrupted with just the mechanical effect of the placement of the stent. And the endothelium is also the non-adhesive protective layer that's coating the vessels, that's preventing the circulating platelets from coming in contact with the subendothelial collagen and connective tissue, which is highly, highly thrombogenic. So with patients that have drug-eluting stents, if the vascular endothelium has not regenerated appropriately, some patients can end up with stent thrombosis. Now, unlike in-stent restenosis, thrombosis is an abrupt occlusion. There usually has not been enough time for collateral flow to develop. And so these patients can end up with MI and sudden death in a large population. And that's why the hype about antiplatelet therapy and drug-eluting stents, and that's the reason. The other thing is with bare metal stents, because there is no drug embedded in there that prevents vascular endothelium regeneration, the endothelium usually grows over the stent and covers the metal over a period of a month or so. The metal part is also thrombogenic. And once that gets covered up, the risk is much reduced for stent thrombosis. And this takes much longer in drug-eluting stents, and depending on the patient pharmacogenetic factors, it may happen faster or slower, and it's hard to predict which patient will respond in which particular way with drug-eluting stents. So in order to keep the definitions uniform for research purposes, the Academic Research Consortium has certain definitions. Stent thrombosis is considered acute when it happens within 24 hours. It's considered early when it happens within 30 days of stent placement, late when it happens within a year, and very late when it happens more than a year after stent placement. Now, as you can see here, that acute and early stent thrombosis, the incidence in bare metal and drug-eluting stents is almost the same. And that's because both are high risk because the endothelium needs to have time to regenerate. However, you can see that there's a several-fold difference between the late and very late stent thrombosis in the bare metal and drug-eluting stents, and I just explained why. This autopsy series compares 23 drug-eluting stents with 25 matched bare metal stents over a period of 1 to 4 years after stent placement. And the authors examined these stents for the degree of endothelialization. And you can see here that with the bare metal stents, here it seems like it's almost completely endothelialized within a few months. However, the drug-eluting stents, at best, are 50% endothelialized, even years after stent placement. So that kind of brings into perspective why it's important. So what can we do about it? I mean, we know that it's going to be poor endothelialization. What can we do? That's the importance of antiplatelet therapy. This is the representation of the surface, a very complex surface of a platelet. And it has all the various receptors that the platelet has, including the receptor for aspirin, the P2Y12 receptor for clopidogrel or Plavix. And this is also the receptor for many of the other drugs that we are familiar with that are used for patients with stents. And then there is also the glycoprotein receptor, which a lot of the intravenous drugs that are used in the cath lab work on. And it's also important to remember that there is significant crosstalk between these various receptor sites. So during the high-risk period, which we just talked about, usually blocking just one receptor is not enough. And that's where the concept of dual antiplatelet therapy comes in for the high-risk period. And typically, the two agents that were used for the longest time, the dual antiplatelet therapy, was aspirin and clopidogrel, or aspirin and Plavix. Keep in mind that up to 30% of patients may be non-responders to one or both of these drugs. That could be for various factors, such as non-compliance and absorption. However, a big factor is pharmacogenetics of the patient. Remember that clopidogrel is a prodrug. It gets converted to the active form of the drug in the liver. And for that, there's an enzyme that not 100% of patients have. And so it becomes really important in the high-risk patients where if they are placed on dual antiplatelet therapy with these agents and it turns out that they're non-responders, they may still thrombose. So that becomes really important. Fortunately, we do have several other drugs in this class that are much more potent, and they are much more reliable in terms of pharmacogenetic factors. And so we may encounter patients that are not on aspirin and Plavix, but they might be on one of the other drugs, either because the cardiologist felt that they are very high risk due to their lesions, which might be multiple, and because of angiographic risk factors, or it might be that they are non-responders. There is, by the way, a blood test, a point-of-care blood test that is available that cardiologists sometimes use that can predict responsiveness to these medications. And also, it turns out that the Asian population seems to be more resistant to these drugs. There was a big, in the news was a series of cases that were reported in the mid-2000s, around 2007, with cases of stent thrombosis that happened in patients with drug-eluting stents that were undergoing surgery. And this is a composite of 2 landmark studies that were done at the Mayo Clinic about the incidence of major adverse cardiac events with the timing of surgery after stent placement. And as you can see here, and it was on the cover of Anesthesiology in 2008, because that was a big deal back then, where we had the first generation stents in use. And what we see here is that with bare metal stents, the major adverse cardiac events sharply decline within a couple of months. However, with drug-eluting stents, that was not the case. Even past a year, the adverse events continued to be to be relatively high. And this kind of goes along the lines of what I showed you earlier about the endothelialization. That does not happen completely in patients with drug-eluting stents. So keep in mind that since the publication of those two landmark studies, stent technology has undergone a pretty explosive evolution. The newer stents that we now have available are much thinner, more flexible, and much more biocompatible, easier to navigate, and the results of those stents are much better. You will also see here that the scaffold material has changed from stainless steel to several other alloys, which are much more biocompatible and stronger. And also you will notice that the drugs are different from the ones that were used earlier, which are also more effective in preventing thrombosis. Also, the other thing to note is that the newer stents have biodegradable polymer. So you remember the coating that I talked about that is placed on these stents for the for the drug to be embedded in? That polymer is one of the culprits that causes the thrombogenic potential. And so with the evolution of technology, there have been stents that have been made where the polymer is biodegradable, which means after a certain period of time, it dissolves and it goes away so that one thrombogenic component is gone. Also, you will notice that there are stents that are available that are polymer-free now. So essentially, it's the scaffold that is just coated with the drug. There is no polymer there. So that reduces one thrombogenic potential. Also, at the bottom is something I will get back to in a little bit, is the, trying to get to the pointer. Anyway, at the bottom is the BVS, the bioabsorbable vascular scaffold. So that is a very interesting concept, which came from trying to minimize the thrombogenic components at the foreign body, within the human body. And the concept is that that particular stent completely absorbs and disappears altogether. Not just the polymer, it's the entire stent. And that stent is no longer in use, and I will talk to you about why that is. Talking about the development of newer generation stents, this is a Italian registry that looked at over 39,000 patients, and they were prospectively followed over a period of 5 years, of which a large percentage had surgeries. And here the authors noted that surgery within the first year of stent placement was fairly common, as we already know. And they felt that the stratification of these patients with bleeding risk and thrombotic risk is really important in ensuring better outcomes. And they also found that newer generation drug-eluting stents were safer than older generation drug-eluting stents when surgery was performed within a year of stent placement. However, along the lines of new technology, we have to be very cautious. I talked about the bioabsorbable vascular scaffolds, and I said I'd come back to it. So it's a very novel concept, and because it provides temporary mechanical support while it's needed, and then the stent is supposed to disappear completely to remove the foreign body and get rid of that reaction of stent thrombosis provocation. However, this study, they looked at a randomized control trial comparing bioabsorbable vascular scaffolds with metallic stents. And these results were reported early because of safety concerns. And they found that there was a much higher incidence of stent thrombosis in the bioabsorbable vascular scaffold. And the 2-year event rate was several-fold higher. The odds ratio was 3.5. And so the FDA issued a safety alert, and the stent was withdrawn from the market. It was approved in 2016, and it was withdrawn in 2017 for clinical purposes. However, there were a large number of patients that already had these stents implanted, and it was also not withdrawn as far as research goes. And so there were patients that continued to have these stents placed for research purposes. So even though these are no longer in use, just keep in mind that we may still come across patients that have had these stents in the past, and they may present to us. So the same group from the Mayo Clinic that published those 2 landmarks about major adverse cardiac events in first-generation stents, went back and did a retrospective review in 282 patients and looked at the incidence of major adverse cardiac events in patients with second-generation stents this time. And they found that the incidence of MACE was not insignificant, and it was highest within the first 6 months of stent placement still. And there was also a risk of excessive bleeding because these patients were on antiplatelet therapy. However, they concluded that future larger studies are needed. This was just an observational trial, and it was a small sample size. So larger studies are needed that can guide us into the best timing for surgery for patients that have stents. And we still don't have any randomized controlled trials that will answer that question. So there is no doubt that technological advances have reduced the incidence of major adverse cardiac events. However, that has brought the awareness that bleeding is still significant and it still impacts hard outcomes such as mortality. And that's where the concept of net adverse clinical events was conceived, where they looked at not just the thrombotic events, but also the bleeding events, which lead to adverse outcomes. And with that, in the last few years, there have been multiple trials that have come out that have emphasized shorter and shorter duration of dual antiplatelet therapy in order to reduce the bleeding risk in these patients. To the point that there was an editorial that recently came out in JAMA, which questions how short is too short. You will see that patients will present to you with stents placed that have only been on dual antiplatelet therapy for 1 month, and they're presenting for surgery. So, the question is how short is too short? Yes, it decreases the bleeding risk, but what about the thrombotic risk? So this is an example. In 2020, the FDA approved the Resolute Onyx stent, and they said for patients with high bleeding risk, it's safe to just do 1 month of dual antiplatelet therapy for these patients. A year later, the Xience stent was approved by the FDA, and they said for patients with high bleeding risk, it's fine. Dual antiplatelet therapy for 28 days is safe and effective. Stent wars continued. A year later, there was another stent, the Biosensors BioFreedom stent, that also said that patients with high bleeding risk, it's fine to do dual antiplatelet therapy for just 1 month. And therefore, we now have patients that are presenting with shorter and shorter durations of dual antiplatelet therapy. To the point that in 22, the ACCHA guidelines on the recommendation of dual antiplatelet therapy in patients after coronary stents said that in select patients, it's okay to stop aspirin, which used to be something that was continued indefinitely in patients with coronary stents. Now, with the newer studies that came out, some of them suggested that stopping aspirin and just continuing the other P2Y12 agent was okay in a select patient population. So they said it was okay to stop it after 1 to 3 months. However, they did have the disclaimer that these studies, these approvals are not based on studies that have been done on the perioperative population. So just keep in mind that the patients that the cardiologist is seeing is very different from what we are going to be seeing in the operating room. None of the studies have been shown to be effective in terms of perioperative risk for these patients with just abbreviated dual antiplatelet therapy. So what is it about the perioperative period that we should be concerned about? So we know that all of these patients that are showing to the outpatient cardiologist still have the same risk factors. They have coronary disease, they have hypertension, renal insufficiency, they have had a stent placed, so there is endothelial damage. And of course, if the patient has a drug-eluting stent, there has not been enough time for the endothelial damage to heal, especially if the stent was placed for off-label use. And I'll get to what off-label is. And then you add to it the perioperative stress response, which you know that it increases platelet activation from the baseline. It causes vasospasm, which narrows the arteries further. It decreases the fibrinolysis, which makes them more prothrombotic. The surgical period causes sympathetic activation from pain, shivering, and all the other causes that we know happens in the perioperative period, which increases the shear stress on an endothelium that's already not regenerated. And of course, it causes inflammation, and it's overall a prothrombotic process. So that's why the patient that is an outpatient, and it's okay to stop dual antiplatelet therapy in 1 month, may not be equally safe in the perioperative period that we need to be aware of. Along comes the surgeon and wants to stop the dual antiplatelet therapy. So it turns out that stopping antiplatelet therapy not only reverses the antiplatelet effect, there are studies that show that actually causes a hyperthrombotic rebound. And so now the platelets are all of a sudden hyperreactive, not just from the stress response, but also from stopping the antiplatelet therapy. And this rebound effect happens to be the maximal at 4 to 10 days, which is exactly when the patient will present to us after stopping dual antiplatelet therapy. So if a patient with a coronary stent presents to us for non-cardiac surgery, they're already hypercoagulable. We have 2 options. We continue the antiplatelet therapy, which predisposes them to bleeding, which has an impact on heart outcomes, including mortality. And we have the option of stopping the antiplatelet therapy, which predisposes them to stent thrombosis in an already hypercoagulable patient. So what do we do here? What guides us in what's the best time for performing surgery? We don't really have any randomized control trials, as I already told you. What we do have is guidelines. Now, guidelines are systematically developed recommendations which are meant to assist us. However, they cannot guarantee any outcomes because they're mainly based on observational studies, which are often conflicting, and they're based on expert opinion. They are not intended as absolute standards. Therefore, clinical judgment and common sense is still required in spite of having those guidelines in place. So with the evolution of coronary stents, the guidelines have also evolved, and I'll go over a little bit of how they have evolved. So when bare metal stents were approved in 1993, there were absolutely no formalized guidelines that existed. In 2000s, the adverse event reports came out after bare metal stents that the patients were not doing well. So the guidelines proposed in 2002, and they suggested delaying surgery for 6 weeks in patients that had bare metal stents. Then drug-eluting stents were approved in 2003, and then over the next several years, about 290 pretty adverse cases were reported from the perioperative arena to the FDA. There was an emergency actually meeting in 2007, and then the guidelines were promptly revised, and they recommended postponing non-cardiac surgery in patients with drug-eluting stents for 1 year after stent placement. Then the second generation data emerged, and we talked about how the stent technology has evolved, and the results were encouraging. They got safer. So the guidelines were again revised in 2014, and they were somewhat liberalized, where they suggested that, yes, it's safe to wait for a year, but you could consider having surgery after 6 months in patients with drug-eluting stents. Then the newer generation results kept coming out, and they were more favorable. And the guidelines were again revised in 2016, and they were further liberalized, and they said postpone surgery for 6 months, but maybe consider it at 3 months. And then again, the guidelines were supplemented, and these are the dual antiplatelet therapy guidelines. And then they recommended more of a personalized approach, and this is when the abbreviating dual antiplatelet therapy became in vogue. And they started going shorter and shorter on the dual antiplatelet therapy. And then most recently, the guidelines were updated in 2024. And just briefly, they suggest postponing surgery from 6 months to 1 year. However, they recommend a shared multidisciplinary decision-making process because it's not all black and white. There are several shades, and each patient has to be taken individually. I will go over these guidelines as we go back to our case in a bit, but this is basically the gist of all the evolution. These are the documents for the most recent updates, the 2016 and the 2021 that I just mentioned. And this is the most recent document that talks about the 2024 update, which is a cardiovascular management of non-cardiac surgery, and it includes the patients that had coronary stents. Regarding guidelines, this retrospective review from several years ago looked at over 126,000 patients. And they looked at the patients that had cardiac stents in the VA system. And here what we see is that the top line shows that a large percentage of patients do need procedures. It's talking about percentage of patients that had surgeries within the first year of stent placement. And you can see almost 20% of patients were having surgeries within the first year of stent placement. However, you see in the light gray there, you see that decline in the percentage of patients that were having non-cardiac surgeries after stent placement. And the top one is the drug-eluting stent, the bare metal stents, and the bottom one is the drug-eluting stents. And this is when the 2007 guidelines came into effect, and which suggested to postpone surgery for 1 year after stent placement. So what we are seeing here is that guidelines do get implemented in practice. So they are helpful, but we need to be using our judgment in order to do that. On the other hand, there are studies like this Danish registry of over 22,000 patients that looked at patients that had drug-eluting stents between 2005 and 2012. And they evaluated the risk of MI, cardiac death, and all-cause mortality at 30 days. These authors concluded that, yes, there is an increased risk in patients that have stents placed and have non-cardiac surgery. The risk is, however, highest within the first month. And so they challenge the guidelines and say that surgeries should perhaps be undertaken sooner than the guidelines suggest. So also, there is a European guideline. They were last updated in 2022. They are pretty consistent with the American guidelines. However, they might be a little more liberal in certain instances. And for our purposes, we'll stick to the American guidelines, which is pretty consistent with European guidelines. So with that, let's go back to our original case. It's a 56-year-old lady with a recent diagnosis of cancer, has all the risk factors, and has coronary disease. Now she has stents that were placed 7 months ago, multiple stents. She also has cancer, and that's a risk factor for thrombosis in itself. She's on dual antiplatelet therapy that's been recommended for a year. However, she's now having surgery, which is required because it's sort of a time-sensitive procedure. So with that in mind, let's talk about when is it safe to proceed with elective procedure. This, although is a semi-elective procedure, but we can go over the guidelines to figure out what they say. So as far as the 2024 update, the guidelines say that in patients that have only had a balloon angioplasty, they say that it's okay to proceed with surgery at 2 weeks. Patients that have had a bare metal stent, they recommend waiting 30 days, which is the highest risk period we talked about for both bare metal and drug-eluting stents. For patients that have had drug-eluting stents and the stent was placed for stable ischemic heart disease, such as for our patient, they recommend delaying the surgery for 6 months. However, the guidelines also say that if a patient has angiographic risk factors like multiple stents or left main disease or bifurcating stents, it might be reasonable based on a multidisciplinary decision to wait a year. However, for patients that have had a stent placed for acute coronary syndrome, such as an MI, they recommend waiting 1 year for elective procedures. Now, they do talk about delaying surgery for at least 3 months in patients that have time-sensitive surgeries that they need, such as for cancer or other surgeries that cannot wait. And they say that it's definitely not a good idea to do surgery within the first month, and that can cause harm. Of course, there will be situations where there is not an option to wait, but they say less than 1 month, don't do surgery. If it must be done, wait at least 3 months. Ideally, 1 year for acute coronary syndrome and 6 months for stable ischemic heart disease. You will notice here that they don't really say what we need to do about between the 1 and 3 month period. And that might be intentional. It's a judgment call depending on the urgency of the surgery. And they say to also bring the patient into the decision-making process and make them understand their risks so that an appropriate decision can be made. Moving on to the next question, how should perioperative dual antiplatelet therapy be managed in our patient? So as far as the guidelines go, They say that it should be a multidisciplinary shared decision-making process, with including the surgeon, the anesthesiologist, the cardiologist, as well as the patient. As far as aspirin is concerned, it is always recommended to continue aspirin whenever possible. If it's a time-sensitive procedure and it needs to be done within the high-risk period, and dual antiplatelet therapy is an option, it should be continued if possible. There will be situations where both agents may not be possible to be continued, like in neuro cases or other high bleeding risk procedures. However, whenever possible, they recommend that it should be continued. In patients that are on oral anticoagulant monotherapy that have also had a stent. Now, this is a subcategory of patients that also came up with the newer abbreviated therapy where a patient that has AFib might need a stent. And so these patients, for a period of time, will be on triple therapy, which means they'll be on dual antiplatelet therapy for a period of time, and they're already on their oral anticoagulant. So some of the studies and class 2 recommendation in the antiplatelet therapy guidelines, as far as decreasing the bleeding risk goes, do suggest that some of these patients might be transitioned to just one agent after the first triple therapy is completed. They may be transitioned to dual, and then maybe aspirin and Plavix will both be taken away, and they will just be on one agent. And that's just to reduce the bleeding risk. So as far as those patients are concerned, the guidelines say with patients that are on oral anticoagulant monotherapy should be transitioned to at least aspirin before that is stopped and surgery, because most surgeons will not want them to be on something like Eliquis. They will definitely want that stopped, which will now leave the patient with nothing, no antiplatelet therapy at all. So in those cases, they say to transition the patient to at least aspirin and then stop the oral anticoagulant. And also, in select patients that need to have a high thrombotic risk procedure, and it's a high bleeding risk that the antiplatelet therapy must be stopped for, those patients should be bridged with intravenous antiplatelet agents, which I will talk about as well. This is new in the American guidelines. It's always been in the European guidelines, but the bridging therapy has now been mentioned in the American guidelines. So I'll tell you a little bit more about how to go about that. This subgroup of the POISE-2, which is the largest study that looked at the benefit of aspirin in the perioperative population with high-risk procedures, cardiac risk procedures. The main study, which looked at 10,000 patients, suggested that there was no benefit of continuing patients on aspirin. In fact, it increased the bleeding risk. However, in the subsection of the POISE study, which looked at about 234 patients, they found that in contrast to the main results, there was a benefit of continuing in aspirin in patients that have coronary stents. So again, that kind of supports the theory, that supports the recommendations of the ACCHA 24 update to continue aspirin whenever possible. Is a cardiology consult needed? It's not so much about a consult anymore, it's about shared decision-making like we talked about. So the cardiologist should, as much as possible, be brought into the discussion in trying to formulate a plan for this high-risk patient that's having a procedure that will predispose them to bleeding and thrombosis. So I was talking about the FDA-approved indications. So just keep in mind that only less than half the patients have stents placed for on-label indications, which includes one lesion, native vessel, stable coronary disease, certain diameter of the vessel, and a certain length. The majority of patients have a higher risk of thrombosis, and these are off-label indications that the stents are placed for. And this includes patients with LV dysfunction, diabetes, renal failure, which is almost all of our patients, patients with 3 vessels, PCI, more than 3 stents placed, overlapping stents, which our patient that we discussed had, bifurcating stents, a long total length of stents, history of prior stent thrombosis, and of course, if the stent is placed for acute coronary syndrome. So that puts the patient in the high-risk categories. Also, since stent thrombosis is a true medical emergency, an immediate diagnosis and transfer to the cath lab is required, usually recommended within 90 minutes, is the definitive treatment for this in order to have a good outcome. It should be performed in an institution where you can easily have access to an interventional cardiology service, which has a 24 availability in a high volume center where experienced interventional cardiologists are available. And it may not be in the same institution that the surgery is being carried out. However, if you have an understanding with an institution that you can get your patient there within 90 minutes, that might be acceptable. Also, these patients have to have pretty intense perioperative preparation. There needs to be an individualized, multidisciplinary, shared decision-making process where it might include making a call to the interventional cardiologist, talking to them and saying, we have a high-risk patient that's going for surgery on the table. What's your schedule like? If we get into trouble, are you prepared if we bring this patient over to do the intervention and potentially avoid a bad outcome? And of course, counterbalancing the risk of bleeding thrombosis and the risk of delaying surgery, in this case, cancer surgery. We cannot indefinitely delay the procedure because this patient has cancer. And therefore, monitoring, vigilance, and tight hemodynamic control and good venous access, because we know that this patient is also predisposed to a bleeding risk, where we have blood product and platelet availability. So we come across situations where the surgeon might say that the patient's not on antiplatelet therapy, but they're on sub-Q heparin. Now, that should be protective for the stents. And what should be the response to that? There have been complex anticoagulant regimens that have been evaluated, including heparin. And it has been found that heparins alone do not have adequate antiplatelet effects. In fact, if a patient is on heparin, which is abruptly stopped, they can have rebound prothrombotic effects. And therefore, the cornerstone of antithrombotic prophylaxis is still dual antiplatelet therapy. Now, what if the surgery has to be done within the 0 to 6 month period in a patient that is very high risk of bleeding, as well as really high risk of thrombosis? We talked about the guidelines mentioning the bridging therapy. So what do we have available to us? We have a drug. We have certain intravenous drugs. We have several. The most practical seems to be Cangrelor, which is a drug that has immediate onset. It is a P2Y12 receptor inhibitor. It has a very short plasma half-life, within minutes. And offset of action is within an hour usually. And it has been evaluated in certain case series, not as a randomized controlled trial for bridging therapy, but in certain case series in that dose that's mentioned. And also, it does not require any adjustment with renal failure because it metabolizes independent of renal function. So this is an example of one of those studies that was a prospective single-center experience of Cangrelor. As a perioperative bridging therapy in a series of patients. They used a dose of 0.75 mics per kilo per minute in 27 patients, including cardiac and non-cardiac procedures. Out of these patients, 2 cardiac patients had bleeding events, and none of the non-cardiac patients had any significant bleeding events. However, they safely got through the procedure without any thrombotic events. So how would it look in the clinical setting if we had to bridge a patient? So let's say a patient comes to you that's very high risk of bleeding and very high risk of thrombosis. And we need to come off of one of the antiplatelet agents in order to get them successfully through the surgery. So this is one suggested protocol, whereas that you would continue the low-dose aspirin throughout, which is the yellow arrow on top. And maybe 5 to 7 days before the surgery, you could tell the patient to stop the oral agent, like Plavix or whatever agent they're on. Then you would admit them about 3 days before the procedure and start this IV infusion of Cangrelor. 1 to 6 hours before the procedure, you would stop the infusion, get the patient through the procedure, and then as soon as they're able to take orally, you would give them back their oral agent so that it can have time to take effect. And you would also restart the intravenous agent to not have them unprotected for that period of time. And then eventually you can stop the intravenous and discharge them on their oral therapy. And similarly, the other agents that are available, you can use the same concept and continue the aspirin and stop the oral agent and start the intravenous agent. However, keep in mind that this is an off-label use of a drug. Cangrelor is not approved for bridging therapy. Although it is an FDA-approved drug, it's approved for as an adjunct to percutaneous coronary interventions in the cath lab. It's not approved as a bridging agent. And finally, it has been mentioned in the 24 update, and although the European guidelines did mention it, so it's probably going to be starting to be used more commonly now. It's best done in collaboration with the cardiologist because they are very familiar with these drugs. They use them in the cath lab all the time. Keep in mind that the bleeding risk is not trivial with these agents. It might seem like it's an ultra-short half-life onset offset, but these patients are at a real risk of bleeding. Also, it needs admission 3 to 7 days prior to therapy, so it gets very expensive. Evidence is equivocal. It's based on just case series, not on any randomized controlled trials, and therefore larger studies are still needed. However, it's still a good option. So after going through all that, we need to understand that the ACCHA guidelines, although they are very helpful, they do have some limitations. We already talked about that these guidelines are not based on any randomized controlled trials. There are no trials in the perioperative setting. Most of the studies that we are basing this on are observational. They're single center. They're usually in a heterogeneous patient population with all kinds of stents, first generation, second generation. And the studies, the patient population is small, and they are usually not adequately powered. And since they are based on evidence from the non-operative outpatient setting, features that are unique to us in the operating room have not been addressed. It does not address, the guidelines don't address the timing of elective surgery if dual antiplatelet therapy interruption is not necessary. So they say that, wait for those time periods if you need to stop one of the agents. However, the guidelines don't really say, what if the surgeon doesn't need you to stop? You can continue both the agents. Is it okay to do the surgery within a month? So the guidelines don't mention that. I would say no, because it's still a very high-risk period. But as far as the guidelines are concerned, they don't really talk about that. Guidelines don't really distinguish the comorbidities and the surgical invasiveness. They do talk about the angiographic risk factors, that if a patient has multiple risk factors, maybe delay the surgery for a year. However, if a patient is having a hernia surgery versus an open thoracotomy, whether a patient has an EF that's normal or if it's 10%, they don't really say whether that should affect the timing of surgery, although it would be a real risk in terms of patient outcomes. And also, it does not address the patients that are on abbreviated dual antiplatelet therapy who are on a single agent. So remember, I talked about how there is a focus on trying to go lower and lower on dual antiplatelet therapy. So we will now come across patients that are on dual antiplatelet therapy for just maybe a month, and then they may stop the aspirin altogether. It used to be that it would be the Plavix that was stopped and the patient would continue on aspirin. Now there are studies that suggest stopping the aspirin might have a better outcome in terms of bleeding and continue the patient on Plavix. So you might encounter a patient that's coming to you a month after stent placement that is only on Plavix, and the surgeon needs to stop that Plavix. So we don't really talk about what do we do with those patients. I would say that patient needs to be started on aspirin, and then you can stop the Plavix and proceed with the procedure. They do mention the oral anticoagulant. If the patient's just on that, then they say to transition to an aspirin, but they don't mention what if it's just a single antiplatelet agent. So that's something that we should keep in mind. So just putting it together, we need to really know all of the antiplatelet agents that our patients might present on in order to effectively deal with the bleeding complications that we might end up with. So we know that aspirin has been available to us for a long time, and just know that it has a very short half-life. It's to the order of like a few minutes. Plavix has also been around for a long time. It has a half-life of 6 hours that some studies will report. However, the active metabolite is only active for a few minutes. So the reason I bring that up is if you get a patient that's been on one of these two drugs and they show up for a procedure and they end up with a bleeding complication, you need to transfuse. Your platelets that you transfuse should be effective because even though aspirin and Plavix, they're both irreversible platelet inhibitors, which means platelets will not work for a week if you put the patients on that drug. However, if you give platelets to the patient, the drug is already gone, and those platelets that you give them should work. So that's to tell you about the half-life of these drugs. Prasugrel or Effient has a half-life of 4 hours. It's like Plavix, it's a prodrug. It is much more potent, has a much faster onset, and it has less resistance to the pharmacogenetic resistance that I talked about that happens with Plavix. However, it has a higher bleeding risk, and it is contraindicated in some patients which have a low BMI or history of hemorrhagic strokes. Ticagrelor or Brilinta is a drug that you will very commonly encounter in patients that are high thrombotic risks that the cardiologist will place them on. This is a reversible agent. Unlike the first three, this is a reversible agent, which means once the drug is metabolized from the blood, the platelets that are circulating will start to work. However, it has a fairly long half-life, which is 8 hours, which means for 2 days, 6 half-lives, 2 days, the platelets that you transfuse may not effectively work. So you have to keep that in mind that if you get a patient that and ticagrelor is usually a twice daily dosing. So if a patient emergently shows up to the operating room for a ruptured aneurysm or something and they just took this medication, you may have a very hard time with just giving them platelets in order to control the bleeding. And then cangrelor, which we just talked about, is one of the very important advances. It's a bridging agent. We still need studies, randomized controlled trials to support it, but it has been used in several case series. So how do we manage bleeding in patients? If a patient is showing up on aspirin, usually transfusing is going to be effective, as I talked about. Same thing for Plavix. You might need a slightly larger dose of platelets, but it should work. Prasugrel, even more. Usually if the patient has not had a recent dose within 8 hours, hopefully it should work with a higher dose of platelets. Ticagrelor is the culprit in which platelet transfusion becomes ineffective within the first 2 days. And there you might have to consider other things, just mechanical pressure, maybe factor 7A, or depending on how life-threatening the hemorrhage is. So that's something to be mindful of. Along those lines, something really important related to that is this new drug that is in phase 3. It was supposed to be approved by now, but it hasn't been yet, hopefully soon. It is a novel antibody-based reversal agent for ticagrelor, which we just talked about. That is the most challenging drug to reverse. So the concept is similar to a molecule that encapsulates the drug, and if there is enough concentration, it could probably pull away the drug from the platelet and cause a reversal of the antiplatelet effect. So this would be an IV agent that would be used as a bolus dose and then an infusion until the effect is required. We were approached by the drug company for a trial, which is hopefully FDA approved soon, and then a phase 4 trial. But we are anxiously waiting for that. And then this drug has also been given the priority review by the FDA because it's the only drug of its kind for something like this. And also another drug that's going to be very exciting is selatogrel, which is a novel agent. It is a sub-Q P2Y12 inhibitor, which is kind of the same category as clopidogrel. However, we talked about the bridging, where we need to admit the patient for 3 days and then start them on an infusion and then get them through surgery. Once this gets approved, potentially, the patient could bridge themselves at home. We could tell them to stop the oral agent, start giving sub-Q injections, kind of not bring them in 3 days before, maybe bring them 1 day before, and then get them through surgery in that way. So that's the other development. Likely, the phase 3 trials are underway, and it will probably be completed by end of next year. So going back to our case, what did we end up doing? So since this is a the patient had a non-acute coronary syndrome stent placed, and it has been more than 6 months according to the guidelines. If it is an elective procedure, it should be okay to proceed. However, this patient has angiographic risk factors, multiple stents. So, if this surgery were able to be delayed, ideally it should be delayed for a year. But this patient has cancer, so we need to proceed. So it was decided to stop the clopidogrel for 5 days and continue this patient on aspirin and proceed with invasive monitoring. And the plan was to resume the dual antiplatelet therapy as soon as possible after the procedure. And it was decided to do this procedure in a place where the cath lab was easily accessible. So the patient ended up with intraoperative blood loss, which was promptly replaced. They had a brief episode of hypotension, which was promptly treated. They did okay through the operating room, went asymptomatic, hemodynamically stable to the PACU. However, out of abundance of caution, a 12-lead EKG was done in the PACU, and it showed ST-MI pattern in the inferior leads with an elevated troponin. And the transthoracic echo showed an infralateral hypokinesis. So which tells you that even if everything is done right according to guidelines, vigilance, there is no substitute for that, and then you have to use judgment. And this is, just to catch that. So the patient was reinitiated on aspirin, morphine, beta blockers, nitroglycerin to take care of the myocardial event. However, the cath lab was deferred because the patient remained hemodynamically stable, and they were taken to the cath lab the next day after the bleeding was controlled. They found that the RCA had a posterolateral thrombus, although the drug-eluting stent was completely patent. Nothing wrong with that. This was a brand new lesion. So they did an aspiration thrombectomy, and dual antiplatelet therapy was resumed. The patient ended up doing okay. So to summarize, continue dual antiplatelet therapy and postpone elective surgery wherever possible. For 2 weeks, if it's a balloon angioplasty, for a month for bare metal stents, for 6 months if it's a drug-eluting stent and it has been placed for chronic ischemic heart disease, and for a year if the drug-eluting stent was placed for acute coronary syndrome. If surgery cannot wait, as it was in this case, continue the antiplatelet therapy, whatever possible, and prepare for bleeding. Keep in mind the antiplatelet agents that the patient is on. If the antiplatelet therapy needs to be held, a shared multidisciplinary heart team decision needs to be made, and the patient may need bridging therapy, which we talked about. Stay tuned for investigational new drugs, the 2 drugs that we talked about. And we know that guidelines cannot guarantee any outcomes, so there is no substitute for vigilance, judgment, and adequate preparation. And we still need high-quality randomized controlled trial, especially in patients with drug-eluting stents that are going for surgery. We don't have any trials right now. And with that, I will take any questions if you have any.
When you do bridging therapy after the surgery, do you bridge? Do you put the medication for 2 days after? Or?
No, so the IV agent is stopped as soon as your oral antiplatelet agent kicks in, which if you give a loading dose, it should be within a few hours for Plavix.
The issue comes with emergency surgery patients. A few months ago or a few weeks ago, we had a patient who came with a hip fracture on dual antiplatelet therapy. I think her stents were in for less than 6 months. And to couple that, her troponins were going up during the admission. And I'm in a moderate-sized community hospital where we don't do interventional cardiology. And the pressure was, instinctively, the ER stops the anticoagulant without even consulting appropriately. And we're faced with now, we have to do this surgery within 24 to 48 hours because it's a fractured hip. And a number of things come into concern. One, general versus regional, which is when do you proceed and how do you proceed?
That's a very tough one. I don't know if there is a right answer. And I don't know how you did it, and kudos to you if you did it, but ideally, it should be a multidisciplinary decision where the cardiologist should be right by your side, trying to guide you through this, and stopping the antiplatelet therapy. They would need to be constantly monitored. Yeah, if the surgery needs to be done, you could be on the table proceeding with the surgery, but just keep in mind that at any point, you need to be monitoring the ST. And anytime you see hemodynamic compromise or ST changes, that would be when the patient would have to be rushed to a facility where they can do a definitive treatment. And that would be the only life-saving. So that's a very hard one.
I did the smart thing. I handed off to the person who called in.
Oh, wow. I hope the patient did okay.
I didn't end up following up too much, but it was a big controversy.
Yeah, I don't know. I mean, I don't think anyone would fault you for getting a cardiology consult on that patient.
We did, and the comment was beware of the antiplatelet. We had a lot on standby and available, but I think from your advice, I would do it in a center. It's hard to transfer your fracture, but not impossible.
Mm-hmm.
Do it in a center with the facility of interventional cardiology.
Yeah, there are instances of a soft indication for transfer, but I think this is a real one.
Yeah. Thank you.
I have a question about what is the current recommendation for long-term antiplatelet therapy for stents in general? Because I do get patients who have had stents for years, over a decade or something like that, and they come in on no antiplatelet therapy at all, no Plavix, no aspirin, nothing, and they still see their cardiologist regularly. And I just was wondering, is there at a certain time where they just stop everything altogether?
So with the recent studies that I talked about, it suddenly got very confusing. It used to be that they would be on aspirin indefinitely. However, with the bleeding risk that just got highlighted, it's all over the map. There are patients that will come to you on dual antiplatelet therapy. There will be patients on single agents. There will be patients not on aspirin at all. And there will be patients just on the antithrombotic. So it's, and if the cardiologist has agreed with whatever the plan is, I think
Just go with
that's a team decision that's been made, understanding the risks and benefits. And so, there isn't anything, and there's a class 1 recommendation. They say the class 1 recommendation is, as much as possible, continue dual antiplatelet therapy for as long as possible in high-risk procedures for at least a year and beyond if they have done okay. However, if they have encountered bleeding issues like GI bleeds or bruises or other nuisance bleeding, then they will try to cut it off because that predisposes them to the bleeding, the morbidity associated with the bleeding. And so they will try to cut off.
Do you know if a patient has been taken off everything because of bleeding issues over the years? Do their societies recommend restarting something just because surgery is a prothrombotic event?
So if you're talking about a patient that has stents placed in the past, it would be helpful to figure out how many stents, high-risk stents, 1, 2, is it on-label, off-label? And if it turns out that it's the high-risk category, it would not be a bad idea to at least start them on aspirin.
Like a week before surgery?
Right.
Start aspirin.
Aspirin could even work the day of. I have done it where I've been concerned and I've just given them a loading dose of aspirin and proceed. And you obviously have to check with your surgeon, make sure.
What do you consider a loading dose?
325, yeah. And if they've been on aspirin and they just didn't take it for the last couple of days, then I might just give them back their usual baby aspirin because, it lasts for a week.